Welcome back to my channel, and today is the episode number 4 of the Green Top Guidelines, and this guideline is guideline number 8, which was published on October 2021, and it is amniocentesis and chorionic villus sampling. So let's start with this guideline. Amniocentesis and chorionic villus sampling, and this is updated on 2010, and however it was previously published in 1996 and 2000 and 2005 and then updated on 2010, but this is the latest guideline and was published on the 2021. So what are the key recommendations? Women, they should be informed that the additional risk of miscarriage following the amniocentesis or CVS performed by an appropriate trained operator is likely to be below 0.5%. Amniocentesis, they should not be performed prior to 15 weeks of gestation. CVS, they should not be performed prior to the 10 weeks of the gestations. When possible, to reduce the risk of the technical challenges, CVS, they should be performed from the 11 weeks gestation onwards. The women with the multiple pregnancies, they should be informed that the additional risk of the miscarriage for the twin pregnancy following the CVS or the amniocentesis performed by an appropriately trained operator is about 1%. And screening the result for blood-borne viruses, viral route, and antigen test results, they should be reviewed when an invasive test is considered, and individualized risk of the viral transmission, they should be discussed. So what is the aim of this guideline? It is to provide a concise set of the evidence-based standard of a provision and performance of the amniocentesis and the chorionic villus samplings used for the prenatal diagnosis. So what is the background for this? The pregnant women, they are offered amniocentesis or the CVS for the prenatal diagnosis for a variety of the reasons, including higher chances aneuploidy screening results and the fetal structure anomaly, or non-risk of the inherited genetic diseases. Implementation of the national combined aneuploidy screening and the increased use of the cell-free DNA testing from the maternal blood has resulted in a significant decline in a screen positive results, and therefore fewer invasive prenatal tests they are being carried out. However, both CVS and amniocentesis remains at present the only definitive diagnosis for the aneuploidy in the pregnancy. CVS carried out to obtain the placental villi for the analysis is usually performed between the 11 and 13 plus 6 weeks of the gestation. If required, CVS they can be performed between the 14 and the 14 plus 6 weeks gestation. Individualized counseling of the merit of the CVS versus the amniocentesis, they should be provided for the women considering the CVS during this time period. Okay, so identification and assessment of the evidences, no need to do that. And how should care be organized in providing the amniocentesis and CVS? The scope of this guideline is confined to the technical aspects of the two procedures for the women and her family. Good care in these circumstances encompasses more than the procedure. Women they facing either the procedure, they are usually anxious, and clinicians they should bear this in the mind. The RCOG or Royal College of the Midwives and the Society and the College of the Radiographers, they have provided a consensus statement on supporting the women or and their partners through prenatal screening, which while developed to support the evaluative rule out of a non-invasive prenatal testing and IPT for the Down syndrome, Edwards syndrome, and Patau syndrome. Within the NHS, fetal anomaly screening program is also relevant to the provision of the amniocentesis and the CVS. So these are the evidence 4 and evidence 4 levels. And so what are the additional risks associated with the invasive testing? What is the additional risk of the miscarriage associated with the amniocentesis and the CVS? So what are the recommendations? The women they should be informed that the additional risk of the pregnancy loss following the transabdominal CVS performed by an appropriately trained operator is likely to be below 0.5%. And women they should be informed that the additional risk of the pregnancy loss following an amniocentesis performed by an appropriately trained operator is likely to be below 0.5%. If the amniotic fluid appears cloudy or the purulent, or there are the clinical features of the intra-amniotic infections, consider the microbial analysis and antibiotic treatment. So there is against the level 1 evidence, and 2 plus, and then again 2 plus, and level 4, and again level 4. So what other risks are associated with the amniocentesis and the CVS? The second sampling, the repeat procedure, and the blood stain samples, and the confined placental mosaicism, and the maternal cell contaminations, rapid test failure, failed cell culture, and swear infections, fetal injury, and the maternal vessel injuries, they are the main associated risks with the amniocentesis and the CVS. The women, they should be aware that the results of the CVS, they can be affected by the confined placental mosaicism is about 1 to 2% of the cases. If there is a fetal structure anomaly, it is reasonable to move forward with the discussion regarding the ongoing care, including the option of termination of pregnancy if the woman or the couple they wish to consider this. If there are the no structural anomalies and the PCR results following the CVS suggest a chromosomal anomaly, a full karyotype, they should be awaited before any decisions they are the made. Discussions under these circumstances, they should reflect the RCG, RCM, and Society and the College of the Radiographers consensus statement on the prenatal testing. So, what is required for the training and the maintaining good practice for the amniocentesis and the CVS? And achieved competency with the maternal fetal medicines, sub specialty training, and the fetal medicines advanced skill training, and the modules of the equivalent international qualifications and stimulation training and directly supervised procedures are integrated. And to maintain the good practice, maintain the competency by the competing on or the supervising ideally a minimum of the 20 amniocentesis or the CVS procedure annually, and communication skills training, and the continuous audit and the multiple insertions failures, bloody taps, and the procedures related losses be prompt BTB within 14 days of the procedure, and 6 support for a more experienced operator if the anticipated encountered difficulties, and the review the practice when an operator's annual loss rate of the normal baby exceeds the 3% for either the amniocentesis or the CVS. What are the additional risks associated with the invasive testing? The severe maternal sepsis is a very rare complication. Infections may arise from the organisms and presents on the skin, ultrasound sound probe gel, or the by the needle puncture of the bowel, and skin contamination, use of the separate sterile gel and the sachet, and enclosing the ultrasound probe in a sterile bag, and continuous ultrasonograph sounds are recommended prior to the amniocentesis and the CVS. If on inspection amniotic fluid has a cloudy or the purulent appearance, or the women they shows the clinical features to suggest the intra-amniotic infection, the operator they should consider the sending a small quality or quantity of the amniotic fluid for the microbial analysis and consider the antibiotic treatment. At what gestation should the amniocentesis and the CVS be carried out? At what gestation should the amniocentesis be carried out? Amniocentesis should be performed after the 15 weeks of the gestation. And there is good evidence that the amniocentesis should not be performed before the 15 weeks of the gestation, owing to the high risk of the pregnancy loss and the potential for the talpes equinovirus. So, individual laboratories they have reported increased risk of the obtaining the low quantities of the DNA from direct extractions when the amniocentesis is performed before 16 weeks, and clinicians they should be aware of the potential for the impact or the turnaround the time for the results to allow the informed discussion during the consent process for the procedure carrying out before the 16 weeks of this gestation. So, what should the CABS carried out? The CVS they should not be performed before the 10 weeks of the gestation, and when possible, CVS they should be performed from the 11 weeks gestation to reduce the risk of the technical challenges and possible associations between the CVS and both the oromandibular disruptions and the limb reduction defects. They were first reported in 1991 following procedures carried out between the 8 and 9 plus 3 weeks gestation. Since then, reports have emerged refuted the associations, though more procedures they were performed after the 10 weeks, and it is possible that any potential risk or is gestation dependent, and a result the most guidelines they discourage is performing the CVS before 10 weeks of the gestation. And initially, CVS prior to the 11 weeks gestation, they can be more technically challenging due to the access and the thinner, less developed placental tissue. So, what are the considerations when the performing the amniocentesis or the CVS for the multiple pregnancies? And women considering the amniocentesis or CVS, they should receive detailed counseling and pregnancy mapping by the suitable trained healthcare professionals. And in multiple pregnancies, amniocentesis or the CVS they should be performed by an operator with the skills to perform the selective termination of the pregnancy if required. And women with the multiple pregnancies they should be informed that the additional risk of the pregnancy loss for the twin pregnancies following the CVS or the amniocentesis performed by a skilled operator is around 1%. And women with the multiple pregnancies and a confirmed diagnosis of the anomaly for amniocentesis or CVS, they should be provided with the informations and supported in a directive way, and including the referral to the specialist counseling and services if required. So, a high level of expertise in the ultrasonography scanning is essential for the operators and undertaking the amniocentesis or the CVS and the multiple pregnancies, because uh, pregnancy needed to be mapped with a great care. Mapping is essential prior to any invasive testing to ensure each fetus is identified and sampled appropriately, with a sample labeled correctly for the analysis. As some women and the couples, they may choose a selective termination of their pregnancies based on the results of the amniocentesis or CVS. It is recommended that an operator's skills is performing the selective termination conducts the fetal mapping, as it is unlikely that any operator they would be comfortable performing the selective termination based on the labeling and performed by a referring doctor. So it is also possible that the true amniocentesis related risk of the pregnancy loss in the twin they may be less than 1%. Data for the procedure related pregnancy losses following the CVS are more limited. So, what are the role of the third trimester amniocentesis? The risk associated with the third trimester diagnostic amniocentesis, including the risk of the preterm labor, they are likely to be low. Women, they should be informed that there is a high risk of the cell culture failure with amniocentesis performed in a third trimester. So, what are the risks of the mother to child transmission of the infection? And screening results from the blood-borne viruses, a viral load, and antigen test. The results, they should be reviewed when an invasive test is considered, and individualized risk of the viral transmission, they should be discussed. When screening results for the blood-borne viruses are not known, testing they should be delayed until HIV status they can be determined. The risk of the mother to the child transmission of the HIV for a woman on highly active antiretroviral therapy is very low. Antiretroviral treatment, they should be optimized to aim for an undetectable viral load prior to the amniocentesis or the CVS. The risk of the mother to the child transmission of the hepatitis B is low, with the viral load less than 6.99 log 10 copies per ml, but increased with the higher viral loads. There is no evidence of the risk of the mother to the child transmission of the hepatitis C based on the limited data available. Recent studies demonstrate a very low risk of the mother to child transmission of the HIV for the women on the high active antiretroviral therapy HAART with undetectable viral loads. And a multi-century retrospective case control study, including 166 amniocentesis procedure published in 2009, reported a non-significant increase in the MTCT for women without the antiretroviral therapy, 25% versus 16.2, and for those treated with the zidovudine monotherapy or a double nucleoside reverse transcriptase inhibitors combinations, 6.1 versus 3.3. So the overall risk of the MTCT for the hepatitis B is low, but increasing viral load is a risk factor of the transmission. A small retrospective case control study of the infant of the HBS antigen positive woman, of whom 63 by 642 has amniocentesis, demonstrated a significant increase in the MTCT when the HBV DNA was over 500 copies per ml. There is an absence of the high quality data on the risk of the MTCT with the hepatitis C, but currently no evidence of the risk of the MTCT following the amniocentesis. So here concludes at this guideline, and I hope you like the video. If you like the video, hit a like button and subscribe to my channel. Stay tuned for more RCOG guidelines as well as other guidelines. Take care, stay blessed.